Healthcare continues to be one of the most important topics you think about in the United States economy. And apparently, one of the areas that is focused on even more so right now is the Center for Medicare and Medicaid Services. The agency oversees $1.7 trillion in outlays in healthcare services. To tell us what's going on there right now, pleasure to be joined by Ezekiel Emanuel, who's Vice Provost for Global Initiatives here at the Wharton School. He recently penned an opinion piece in the medical journal Stat about the agency. Zeke, great to catch up with you again. How are you, sir?
Besides being hoarse, I'm great.
Well, I'll try and make this painless if I can. It is obviously an interesting time for healthcare. There's so much discussion. There's even to a level so much concern. But you say that this is an agency, CMS, that really is standing out right now with some of the things that they are doing.
Well, when Trump won, it was the FDA that was a standout under Scott Gottlieb. And I think Mehmet Oz has been doing a great job. He has a lot of independence. He's very focused on bringing modern technology. And they've launched some new initiatives, to get rid of some waste like Wiser. And they're sort of given primary care a boost, and they're also trying to rein in Medicare Advantage, which MedPAC at least suggests has almost $90 billion per year of over billing in various ways, whether through upcoding or selection of patients. So those are important initiatives. I don't agree with everything, of course,
Right.
but that's the nature of policy. You can admire a group without necessarily agreeing on everything that's done. And I think the most important thing one gets is sort of the intention to really try to improve the system.
Right. And because I think a lot of people still believe that where we are right now and where we need to be, there's still a fairly long pathway to try and get to where this healthcare system needs to be in the years ahead.
Uh, uh, I would say there's unanimity on that point,
Yeah.
which is the system is failing. I think everyone agrees the system is failing. Um, what we don't have now, sorry to go off, but political scientists say three things are needed for major legislation and change. You need a recognition of the problem, you need a clear policy, and you need a policy window to open from an election or some tragedy or something like that. We don't have a path forward. We have lots of steps, but they're not a coherent strategy. And I think that's what, over the next few years, we're really going to need to focus on.
All right. So a couple of things that you mentioned and you mentioned in the article, one being the potential financial benefit of doing procedures in facilities outside of hospitals. Take us
Right.
into that.
So it's called site neutral payment. Basically, when the government, as well as private insurance, they pay for the facility where you do the procedure, the surgeon, the anesthesiologist, whatever else. The problem is that when you do the procedure in an operating room of a hospital, a facility fee, which is the biggest portion of it, way more expensive than the doctors, is way higher in a hospital than at, say, an ambulatory surgery center or even a physician's office. And that price differential can be, thousands and potentially more than $10,000, $20,000, depending upon the procedure.
Right.
Many of us have been advocating for, I would say, years, if not decades, that we should have what's called site neutral payment. Wherever you're doing the procedure, you get the same amount of money so that you incentivize it to do it in the lowest cost facility. Look, many years ago, many years ago, a decade ago, hips were only done in hospital.
Right.
Then they made advances and you could do it in an ambulatory surgery center and spend 24 hours. Why are we paying the extra payment to a hospital? It also incentivizes hospitals to get those costs down.
Right. One of the things you also talked about in terms of pay was what primary care physicians get in comparison to specialists, and explain why that stands out.
Well, look, we know that primary care doctors there's good evidence that more primary care doctors actually reduce mortality in a region and increase health. In America, we've had, compared to every other country, we have too many specialists compared to doctors. There's a long history. It really probably goes back to World War II when the military wanted specialists to treat wounded soldiers and gave them higher rank in the military and paid them more. And that
Right.
carried over after a war into insurance. The problem is primary care doctors make, you know, half, a third, a quarter of what surgeons and specialists make. You're not going to attract that many people into primary care, and yet they're critical for improving the health, especially where the primary need is to treat chronic illness and manage chronic illness and keep those people out of the hospital. So increasing the pay of primary care doctors has long been, again, something lots of people have urged, and
Right.
this administration is actually doing something in that direction.
You also noted that the Innovation Center at CMS is doing some good things, and I guess I should say it's continuing to do good things. And having been around business as long as I have as a journalist, we know how important innovation is to all businesses.
Absolutely, and we put in the Affordable Care Act, $1 billion a year to the Innovation Center to develop new payment policies and other innovations that would increase quality or lower costs. Now, the person heading what's called CMMI, which is the Innovation Center, we should champion. He's a Penn grad. He's a former student of mine. I will say he got an A, and he's putting all the good stuff we instilled in him to work. They've come out with several really new models, and we're anticipating another model to drop this month, maybe on Medicare Advantage. So one of the things they've done is they've seen a lot of abuses,
Yeah.
and they've said, listen, Medicare traditionally has not had prior authorization, but areas where we've had abuses, like skin substitutes, that have gone up 40-fold in less than 5 years in terms of billings into the billions. We're going to have prior authorization, and
Yeah.
I think that's actually really important to get rid of a lot of. This is clear. Some of it's clear fraud, some of it's clear abuse, and all of it's waste.
How then do these potential changes being made and the advancements being made potentially impact the insurance industry? Because that's the other side of this equation that seemingly is drawing more and more attention these days.
Well, one of the positive things is they have this new access model, which is trying to get more AI and apps and use more virtual care in. Again, I think one of the really positive steps, and they've collected not just lots of tech companies, health tech companies, but they've also collected a lot of private insurers to say that they're going to participate with the model too and adopt a lot of that innovation, which I think, again, very, very smart move. Something, frankly, the Biden administration did not do enough of. I've been urging, look, you got to put a lot of money behind every
Yeah.
innovation you want adopted because doctors get paid from lots of different sources. Unless they're hearing a coherent message, it's hard for them to change their practice just for Medicare or just for one insurer.
You also noted that there, while we've touched on the things that seemingly are going very well and obviously will help CMS and help healthcare, that there are some things that maybe they still need to address that maybe are not going in the path that they should.
Well, I think, the obvious elephant in the room is Medicare Advantage. More than half of seniors are now on Medicare Advantage. It's hundreds of billions of dollars. And we know that its risk adjustment methodology is antiquated. It's inaccurate. Everyone agrees to that. It's abused. There's a lot of gaming going on. Everyone agrees to that. And yet, Medicare has been glacial, is maybe the best word in revising that. And, when they developed the current risk adjustment methodology almost 30 years ago, they recognized they didn't have the technical skill and they brought in people to help them.
Right.
I don't see that happening. We at Penn have developed a risk adjustment methodology which is 3 times more accurate than what they use. And I have to say, getting a hearing there has been hard.
Overall, how are you feeling then about CMS right now?
Well, look, one is an absolute statement, one is a comparative statement. The comparative statement, compared to all other agencies working for the government, it's the best. I think I can say that pretty clearly. Compared to absolute scale, I think it's going in the right direction. I think there's many other things that could be done that we have urged them to do. Nonetheless, I think if I were to be objective about it, I think compared to the 4 years under Biden, it's better.
Zeke, great to catch up with you again. Thanks for your time and your insight.
Take care.
Thank you. Ezekiel Emanuel, who is Vice Provost for Global Initiatives at the Wharton School.